Actually, maybe just a quick survey. How many folks here are from proton centers? There are actually probably more proton centers here than the number of MR-Iinacs. Anyone have any experience with protons? Yes? Couple? Okay, good. Are you therapists there, or dosimetrists, or physicians there? Okay, very good. Yeah, so I really only have one case, but it's really just illustrative of the potential benefit of protons. I mean, of course, we have, MD Anderson, we've had our proton center since 2006, really built using a Hitachi synchrotron unit. We just actually opened our second proton center in January of 2024, and which is actually also Hitachi, but it's now all scanning beam protons in that new proton center. But I think of course, many sites, including head and neck cancer, protons have very strong benefit. And of course, there's if you know about the data from Dr. Steve Frank's randomized trial in head and neck cancer, there's actually not only significant benefit of toxicity, but also you guys will see that from the publication that will eventually come out, there's even a potential overall survival benefit with the use of protons. So I think toxicity sparing, and that's the really real benefit of proton therapy, is because of the kind of the dose distribution and the sparing of normal tissue does actually portend to better prognosis for patients, particularly the toxicity and morbidity on patients. And esophageal cancer is definitely one of those. And thoracic cancers is really a site where we believe there's strong benefit because of the sparing of the heart and lungs, which actually can, of course, help patients. And esophageal cancer is one of those sites. And one of the stronger benefits of esophageal cancer is because of its uniform location, right? It's always midline, and it's usually, typically, of course, for adenocarcinomas and many squamous as well, particularly like the mid-esophageal cancer case that we saw. Many of those cases, of course, it presents right next to the heart. It's always right behind the heart. And being able to spare the heart and reduce doses to that certainly can potentially benefit the patients. So this is a case of a patient, an 81-year-old, who actually was healthy until started developing dysphagia, kind of a very typical sign, a presentation of a patient with esophageal cancer. This is fairly a number of years ago, because you will see this case is of course, a good outcome case. The patient, of course, had found some narrowing based on a barium and swallow, and EGD shows a squamous cell carcinoma. We don't see that many cases. I think here in Taiwan, you see in Asia a lot more cases of squamous cell carcinoma. In America, in the Western Hemisphere, we see a lot more adenocarcinomas. But in this particular case, a patient has a history of smoking and some little bit of alcohol, but mostly smoking. Actually, a patient has squamous cell carcinoma, which only happens about 25% of patients that we see in the United States. So a PET scan shows a very large mass in the mid-esophagus, mid to distal esophagus, as well as supraclavicular as well as paratracheal lymph nodes, and many gastrohepatic nodes, greater than or equal to 7 nodes. And the EGD in the US finds a T3, fairly locally advanced disease, N3 positive disease. And you can see in the next slide here is that the patient has presentation of fairly advanced disease, local regional disease up in the kind of the upper thoracic region and also the low neck, as well as the distal location, including, of course, the left gastrohepatic areas, nodal areas. Past medical history, patient has a history of cabbage, so has some issue of course, being a good candidate for surgery. In these cases, in esophagus, we still talk about whether a patient could be a candidate for multimodality management. That means in terms of not just radiation, chemotherapy, but also potentially surgery. But for an 85-year-old, typically we don't think about that too much. Of course, patient has a history of smoking in the past, and also some drinking as well, but quit at the time of the cancer diagnosis. Patient lost 60 pounds, was only able to tolerate soft diet, ECOG performance status of 1. So in assessment, this case, we considered M1A with a distal squamous cell because of the high, we considered the upper paratracheal, but mostly the supraclavicular lymph node, to be considered a non-regional lymph node, given the fact of the location of the tumor is a distal location. So we call this an M1A disease, but then not M1B because it has not spread to areas outside of just the non-regional lymph nodes. And so we did initiate systemic therapy with FOLFOX, And then patient did actually have a partial to good response. So then in this case, would you recommend consolidation radiation, chemoradiation, or continuation of chemotherapy in this case? Maybe the physicians in this case. Well, how would you manage this case if you had a case, a patient present in this type of fashion?
We use concurrent chemoradiation.
So after systemic therapy?
No, we do the...
Upfront?
Yeah, upfront, yeah.
Okay, even including patients with a M1A disease like this?
Yeah.
Okay.
I don't think that the SF node is not hard to take away.
Mm-hmm.
We can include it in all the radiation field.
Okay. Yeah. So I think, of course, we initiated because, of course, this patient's, a case like this is always presented at multidisciplinary tumor board, and with a review with all the experts and oncologists and medical oncologists and this was surgeons and radiation oncologists. In this case, because we consider this patient a higher risk patient, of course, has not only symptomatic disease as well. So we actually initiated systemic therapy. I don't think it's wrong to consider starting with upfront local therapy in this case, but because of the extensive nature, we have to radiate a large field. That's one thing. Although I don't think it's going to change our field, regardless when you do it upfront or after systemic therapy. But because really the potential risk for further distant metastatic disease and spread, we decided to start systemic therapy in this case. And this is typically what we do. Is that in patient with even very local, like N3 disease, let's say a patient didn't even have supraclavicular lymph node, but because of the extensive nodal disease, we felt the patient will have a very high probability of having spread if you just do local therapy. And then the subsequent scans after you come back from radiation, patient already have distant spread. So we would want to at least start with systemic therapy to try to eliminate small amount of micrometastatic disease. And as we don't know what's right, but at least this is what we think, logically. And, I guess, is there a role for consolidation radiation? And so I think there's no wrong or right answer, but this is essentially what we did. There is actually, of course, obviously there's a role for consolidated radiation after systemic therapy. There's a number of reviews of this, and this is just one of the reviews in London, in the UK, where they actually looked at in patients who initiated systemic therapy and then whether continuation on chemotherapy and systemic therapy, because they felt these patients are metastatic, right? And so they continue. So standard care is actually to maybe potentially continue on systemic therapy. And nowadays, of course, not just chemotherapy, but even maybe adding immunotherapy in this case, based on patients' PD-L1 status. Or actually, in this case, they also, for some patients, they even actually did some radiation after initiation of systemic therapy. So there was these two groups, not randomized. You see them in the bottom. They're not randomized patients, but actually these are just essentially it's a retrospective analysis. So they actually analyze these two groups to see if there's a potential benefit. And this is, of course, just a table showing in terms of it's fairly well balanced between the two groups, surprisingly, in terms of the patients got radiation consolidation after chemo versus just chemotherapy alone. And you can see here in the patients actually who got some radiation, there seemed to be a benefit because actually local regional progression is still quite a strong possibility for these patients, and that can have some morbidity as well as mortality. And therefore, you're actually initiating some radiation potentially can benefit these patients. But a big argument, of course, is not a randomized trial. So there's some selection, obviously. You always select the best patient to undergo radiation, right? Patients who are progressing on chemotherapy, the patients who are maybe not responding, or maybe have maybe small amount, or maybe these are the patients who have some issues with local disease, you actually still continue on systemic therapy. So there's potential for selection bias that you see with these results. But what they did find, of course, if you actually look at even subset of analysis, whether a patient had multiple sites of disease, metastatic disease, or not, seems like there's a benefit of radiation for most of these patients, adding the radiation. And also, there seems to be that there is also a role of dose. That means if you actually try to do this more definitively and not just palliatively. So if you actually just give 20 gray and 5, which is a much more palliative dose of radiation, but then, of course, if you feel like the patient can benefit, and so this is a physician decision, right, in terms of whether you want to actually treat these patients more definitively for cure, then, of course, you initiate doses that are higher than 20 gray and 5 fractions. And, of course, another selection bias, but I will say this is more because there's some selection. The clinical assessment is actually quite important in this case, but based on the gestalt and feeling that patient may benefit from more definitive treatment, these patients actually do better. So I think there is some, although bias, but I think there is some clinical decisions made here, and actually that could be a right one, and that could benefit these patients. And there's also, of course, there's some large population data analysis. This is called the National Cancer Database, or NCDB. They looked at 12,000 patients, and these are all patients with esophageal cancer who have metastatic disease. And they actually looked at, in subsetting, these patients who just got chemotherapy and no radiation, no local therapy, who patients got chemotherapy on palliative dose of radiation, less than 50 gray, versus only about 19% of these patients actually have received definitive radiation after completing the course of their systemic therapy. And a number of these patients actually not just sequential chemo radiation, but also 51, perhaps more than half of these patients received definitive concurrent chemo radiation therapy. So they looked at, they did a propensity match analysis, trying to match as much as they can based on patient characteristics and age and everything like that. So if you actually follow this, is that patient who received definitive therapy in consolidation after chemotherapy, there was a benefit, there was a survival benefit. Again, although propensity match, there's always selection bias, but and not randomized trial, but it seems to be, if there's a clinical reason to do definitive treatment based on the patient's ECOG performance status, patient potentially can tolerate, more aggressive therapy, there's a potential benefit for these patients. So that's essentially what we did. So patient actually had a lot of courses of chemotherapy, and that's essentially the MD Anderson way, which actually our medical oncologists love to give a lot of chemo just to make sure that they're responding well. And so they give 7 cycles of chemotherapy. Patient has a partial response. So you see here, this is after 7 cycles of chemotherapy. There was still some residual nodal disease in the kind of upper abdomen. The primary disease still pretty persistent. The upper thoracic, neck areas is fairly responding. Of course, not a surgical candidate because of multiple abdominal lymph nodes. So the consensus, again, patient was brought back to tumor board and was discussed that patient should have consolidative chemoradiation at that point. And we decided we should be aggressive because the disease are persistent, and the only way to eliminate this potentially is using standard therapy, which is chemoradiation therapy. So the target volume is actually quite large because we need to consolidate everything. So we treated everything, including the neck, the middle, and also the upper abdomen. In this case, because of the extensive nature of the disease, we used intensity modulated proton therapy. Okay, because of course, and then if you actually look at this, and that's the great thing about protons, where if you look at photons, this patient will have a lot of dose throughout the entire thoracic. The lungs will obviously be radiated, but of course, you always have to. If you say, okay, I want to spare lungs, then you can't spare the heart, right? It has to compromise. You have to have some compromise. So in this case, let's say in this case, you want to spare the lung, then all the dose will spill through the heart, right? Almost an APPA approach. But then if you want to not compromise the heart, then all the dose was scattered to the lung, especially for the extensive nature of this. So with protons, it's just very, very elegant in a sense, because you have really just practically 2 beams posteriorly. You have an exit dose that's practically none for protons, so you have practically no dose to the heart. And this is the type of cases where I think for a mid location like this, where the protons really shine. And of course, you can see here is that we included not only the upper abdomen, but also the upper neck areas. You can see the heart dose, which is amazing here. So we actually did compare. I don't have the comparative plan here, but the comparative plan is the heart is literally looks like that. Okay, right? Because heart was 25 gray mean heart dose. In this case, the mean heart dose is only 12 gray. So more than half the heart is spared. Very low dose to the lungs. So overall, a very, very nice dose plan for this. So patient completed chemoradiation. This is actually many years ago, 10 years ago now. Significantly improved during therapy, gained pounds during chemoradiation, only had minimal adenophagia, grade 2 adenophagia, just a little bit of numbing medicines that were used called xyloxylin. Actually, interestingly enough, first follow-up, there's some questionable upper abdominal lymph nodes that appear to be enlarged. Interestingly, because this is right after chemoradiation, we actually biopsied those. It was positive, left gastric lymph nodes, but because the overall burden of disease responded, we actually decided to just watch this, and patient did not have additional systemic therapy. So we did decided to observe this for every 3 months. What was interesting is actually in this case, so this is the kind of after chemoradiation, 3 months after chemoradiation, we saw there was some residual, although you see the mid-esophageal tumor was completely resolved and there's no additional neck nodes. But in this, interestingly, why these nodes are enlarged, but then actually in a follow-up scan, there was no, that had completed. Okay, perfect, thank you. Good timing, okay. So we're almost done, actually. So this is actually completely resolved without doing anything. It just disappeared on its own. And you can see here, in September 2019, right before the pandemic, actually everything, the patient has complete disease-free without any additional therapy. The patient was actually from Puerto Rico and actually did not decide to, because of the pandemic, did not decide to come back after a year. So here is that the patient did well, very well. Last follow-up, it was lost to follow-up since 2020 because of the pandemic. So will we be any concern about recurrence 5 years out, do you think, in esophageal cancers? Actually, interestingly, so this is the cross data, although you can't say for systemic disease, but this is cross, right, locally advanced disease. What's interesting is that for some cancers, lung cancers and esophageal cancers, interestingly enough, if you actually pass a certain threshold, in this case, about 5 years, if you can get to that point without recurrence, these patients practically would not recur. And so in this case, actually, patient already kind of 5 years out from their therapy, we believe the patient probably doing well, even after, although we lost a follow-up, he hasn't come back since. He's 85, so he probably can die from natural causes as well. But here you can see from the cross data is that the hazard ratio, the benefit of chemoradiation versus surgery alone, there was no benefit after 5 years, suggesting these patients are cured, essentially, with their therapy, and there's no difference between the two experimental groups. And so just to showing you that the dose plans here, this is for lung cancer, this is for esophageal cancer. For IMRT, you can see the difference. IMRT spreads all that dose around the lungs and heart, whereas you can see very elegantly no liver dose and no heart dose, of course. And this is completely unnecessary, right, with photons, whereas protons, you actually really see the benefit here, okay? And actually just to show you that proton being significantly reduced not only the heart toxicity, but we actually did a retrospective analysis showing that patients actually with pre-existing heart disease, coronary artery disease, and other heart diseases, compared to a patient without those pre-existing heart diseases, you really see the benefit of protons in terms of actually toxicity sparing compared to IMRT. Whereas a patient without pre-existing heart disease, they're low risk to start off with, and we didn't really see a benefit. And also we found there was also a potential benefit of lymphopenia risk in these patients because the blood sparing of the protons. We also saw, of course, this is our retrospective analysis, finding a significant reduction in grade 4 lymphopenia with protons compared to IMRT. And in our phase 2 randomized trial that was published a number of years ago now, showing that with protons, you can actually reduce total toxicity burden with protons compared to photons, compared to IMRT, particularly also in post-op complications. So we're trying to prove this now in the phase 3 randomized trial in the United States through NRG let me go back. Through NRG Oncology. So this is we're enrolled about 190 patients is a little bit outdated. So 190 patients in the last month. We had to enroll 3 more patients. So 190 patients out of 300 for this phase 3 randomized trial, trying to prove that protons potentially can have an improvement in toxicity burden in these patients, but also potentially overall survival. And this mirrors another project, another phase 3 randomized trial called PROTECT in Europe, where they have accrued 67 patients. I just got the update yesterday. 67 patients out of 386 for the PROTECT trial. Similar design also, but however, for them, they really just want to assess pulmonary complication reduction in this trial. All right. I think we're going to stop there. I have another case, but I'm not going to go into that. All right. Any questions? Yes.
Nice talk, Stephen.
Thank you.
A quick question. Do you think in esophageal cancer field, we need to split the 2 different histology from squamous to adeno because we know the response may different?
I think we almost have to, unfortunately, because of Esophagus. I'm going to give a lecture later on esophageal cancer that we invariably will be splitting now. A lot of our patients now we see for chemoradiation are the squamous. Because I think the Esophagus was adenocarcinoma, so a lot of our adenocarcinomas who are resectable are just getting perioperative lots now and not getting chemoradiation. I think that's still an area of controversy, I would say, because I'm a radiation oncologist. And I'm going to talk a little bit about organ sparing, organ preservation. I think that's very important. And if you talk about organ preservation, I think it applies for both adenos and squams if you want to spare the patient from surgery. And of course, for squamous cell, patients do essentially respond better to chemoradiation compared to adenocarcinoma. So that just tells you that for adenocarcinoma, if we want to spare surgery, there needs to be improvement in that field in terms of enhancing the outcome after chemoradiation, although it's still not good compared to squamous cell. Yeah.
Maybe squamous patient would have the most chance to organ preservation.
I think so. That's what we observe them, actually. For a lot of our squames, although if you look at the cross, squamous do benefit, but I think a lot of our patients, we do watch and wait after chemoradiation. Because a lot of our squamous are mid to upper squamous, and surgical risks are very high, right? So we try to just watch, after complete response.
Agree,
Yeah.
exactly.
Yeah. Yes?
Do you treat patients with pacemaker?
Very good question. Yes, so we do have actually some particular protons. If they're not pacemaker dependent, we do treat them. Yeah, we monitor though. We make sure that their pacemaker works during the treatment course. But yeah, we do selectively treat them with pacemaker. And also the pacemakers, we're ensuring that they're not getting a certain dose above 5 gray and all those questions. Yeah, we try to meet those constraints. Yeah. Even with protons, we do treat with pacemakers, as long as they're not dependent on pacemakers. Yeah.
In our machine, the pacemaker, the patient with clinic is not allowed to treat by proton.
Yeah, I know. We had that policy before, no longer. Yeah, we just had to evaluate them and assess every time, every day. And then if it's damaged, then we replace it. Yeah. All right. Thank you.
好，谢谢。